Hello, I'm Joelle Hamilton. I'm a medical oncologist in Birmingham, Alabama, and I'm with Urology Centers of Alabama, a somewhat uncommon combination of medical oncology within a large urology group. But the goal that we have is multidisciplinary care, which is really what we're going to talk about today. We're going to talk about PSMA-directed therapies and use in advanced prostate cancer. So kind of the advanced prostate cancer landscape. Where do PSMA-directed therapies fit into that particular landscape? Where does PSMA imaging fit in? And the different trials that form the basis of our use in this particular setting, and really how to collaborate within academics and within a community setting. So I'm joined by some of my favorite people today, and we've got Katie, do you want to start us off?
Yeah. Hi, everyone. I'm Katie Beckerman. I'm an assistant professor at Vanderbilt University. Pleased to be here amongst colleagues to talk about theranostics and radioligand approaches in prostate cancer. Yue, I'll pitch to you.
Yeah, my name is Yue Chen. I'm a medical oncologist at the University of California, San Diego, and thank you for having me.
Glad you're here.
And I'm Carrie Schaefer. I'm a medical oncologist at Vanderbilt University Medical Center, and I'm very happy to be here today to talk about theranostics.
All right, exactly. And the good thing is we've been able to collaborate a lot in the past, and so that'll make this conversation really kind of a natural, organic process. So let's just talk a little bit about how we look at the advanced prostate cancer landscape, and whether we're talking about a PSA recurrence or whether we are talking about de novo metastatic disease, and kind of how we go from there from advanced disease sensitive to resistant, and kind of how you approach it.
Yeah. I'll start off. I think this is the easy one. I feel like the landscape of prostate cancer is just evolving so rapidly. And so while I know we're here to kind of focus on use of radioligand therapy, I think a lot of our studies now are kind of outpacing what we're doing in practice, in the sense that most of our patients in the hormone-sensitive setting sometimes are now even getting triplet therapy. And so it's really, I think, going to be moving up radioligand therapy, and maybe we'll talk a little bit about that today. But for me, I think I see a patient in the who has metastatic hormone-sensitive prostate cancer, and I'm thinking about ADT plus an ARPI, and then whether or not they have high volume disease or maybe are fit enough to get chemotherapy. And really, once you've done all that, if they get triplet therapy, then they're pretty much ready to qualify for an FDA-approved, radioligand therapy.
Exactly.
Which kind of, leads us to the castrate-resistant setting. I don't know if anybody else.
How do you approach castrate-resistant metastatic disease? So whether it's after a doublet or after a triplet, what are you thinking about?
Yeah, no, so I think that's a great question. And usually for patients evolving to castrate resistance, and the thing I would consider first is probably their comorbidity and how functional status. Patients usually got really tired after getting through the first line of therapy. So there's certainly one consideration for that. And nowadays, it's the standard of care to set molecular profiling either through tissue or through liquid biopsy. So that is something I would certainly want to have the information at hand before I start talking about the next line of therapy with my patients.
Right. So you kind of touched upon, we have doublet, triplet options, and then just our landscape has expanded so much. The role of genomic testing, and I guess, Carrie, for you, just where do you put PET PSMA versus conventional imaging when you have a patient that progresses from sensitive to resistant disease?
So, I typically am using PET PSMA when I'm looking for patients to receive theranostics or radioligand therapy. I do use PSMAs also for biochemical recurrence, and then we are seeing a lot of patients who have what we think is high risk disease and localized, and then when we get a PSMA scan for that setting, we realize that they actually have de novo metastatic disease and are probably incurable. But I see a lot that the use of PSMA scans is increasing across the entire spectrum of disease, and I think that the field may go in that direction where it is just our baseline scan for surveillance on therapy and then imaging across the board for all concerns for disease progression. But right now, I think the strongest data is for qualifying for radioligand therapy, and there are some ambiguities that come up with using it in other settings, and perhaps early recognition of very early disease progression that historically we may not be transitioning therapies yet. So that's a space where I think in the future we'll definitely have clear guidelines, and I'm looking forward to that.
Exactly, and I think what you've alluded to very nicely is just we're in the gray area. We're living in the in-between because the clinical trials that we have today were based upon bone scan, CAT scan, metastasis or not. And we have PET PSMA in the biochemical recurrence and in initial staging, and as you said, really the next place that we think about it is going to be if they are a candidate perhaps for radioligand therapy. I think the hard pieces are when PET PSMA is used, whether it is outside of those indications, then I'm not sure exactly what to do. And also just the concept of restaging and how we communicate with each other, but also communicate with patients that yes, we were diagnosed using a PET PSMA, but this is how we're going to follow it. And so can't wait for somebody to fix that problem for us. Yes, yes. And we've had the pleasure of really working together and getting to know each other. And, you're in the academic setting, I've been in the community. And so I think you have been the vanguard, really, of using radioligand therapy. And that came about, I guess a couple of years ago, right after the approval in 22, when really there were not a lot of centers that offered it, but you did. And what I really appreciated was how your team assessed patients. So kind of give us like a great review of what your team did when you had patients to assess for radioligand therapy.
Yeah, I think some of the, seeing the patient and assessing them for whether we think they might be, a trial or, a radioligand candidate. Is first making sure that it's going to be safe for the patient. We know from many of these trials that it's certainly kind of improved quality of life and maybe is easier to tolerate than chemotherapy, for example. But a lot of the safety things I think about and the fitness, I guess, things that I think about are what does their hematologic parameters look like, because we know that Pluvicto can certainly cause myelosuppression. And then is it safe from a kidney perspective? And then, just having a conversation with the patient about what their goals are, what side effects, are they kind of able to go through, willing to tolerate? That's kind of where I start.
Right, right. And then how do you, okay, so I know you're in San Diego now, and so how do you, with your team, you say you've assessed a patient, this is a great candidate for a radioligand therapy, and tell me how you manage those patients.
Yeah, and also we also get referral from community oncologists a lot regarding radioligand therapy, specifically the lutetium PSMA. And I think the first step, if we consider candidate based on the positive PSMA scan. That is the first step. In standard practice nowadays, by FDA indication, patient needs to be on prior 1 line of ARPI treatment and also 1 line of chemotherapy. But I think many of the times we encounter is that many patients refer to us, they are just senior patients, very, very frail, and sometimes they are not great chemotherapy candidates, and we are still considering those to get treatment with Pluvicto or lutetium PSMA. That is still something we are considering in our clinical practice, but not just stringently by the FDA indications.